So welcome back for the afternoon. Just given that I didn't hear people online, unfortunately, we're just going to go through some of the salient points of the case report form just to, for ease of data entry, where it's a RedCap that has lots of branching logic, which means that basically if it's relevant to your patient as far as risk factors or whatnot, it will open the relevant form, but you won't have to enter data for those that it's not relevant for. So basically the start of this is to look at the whether it is a mixed yeast fungemia. So this is referring to at the time of the blood collection, if there were two yeasts identified, then you would answer yes, and that would therefore allow you to enter the relevant information for each isolate. And so that's the mechanism there, and then you can enter the causative fungi with the option of other, and there's a free text there that will allow you to enter ones that are not there. And as I mentioned, a separate form will be able to be entered for each yeast. And we're interested in the first isolate of that yeast. And we also will just have a brief data collection about concomitant bacteremia. So was it E. coli plus the Candida albicans, for instance, would be interesting to know. Likewise, on the very unlikely event, but possible that you might have a Candida plus a fusarium, then you can also enter that as well. This is related to the blood culture collection date, time, how many blood cultures were collected at the time of the fungemia, and how many of those were positive. And was there demonstrated clearance of that blood culture, and if so, what was the date of the first negative blood culture? Helpfully, this is obviously in retrospect, so these patients will have had time to clear their blood cultures and we'll be very clear on which is the first negative. Whether it's from a central venous line or not. And the calendar days of fungemia. How was the isolate identified, and was susceptibility testing performed, and if so, by a local lab or a reference laboratory? The antifungal susceptibility, I've just drawn it up like this because if you try and pull it out of RedCap, it just looks funny. But basically, it will kind of serve as like a table that you can enter the MIC, or whether it was wild type or non-wild type, or unavailable, into this part of the RedCap, and the method by which that was established. Obviously, liaising with the laboratory is ideal to ensure that this data is correct. If you're having any issues with that, let us know and we can try and help facilitate that. And this might need a slight change, but as I mentioned, we'll be piloting this with our local sites to make sure that it all makes sense. But essentially, was this isolate stored at where it was originally identified, and if so, at what laboratory, and if it was sent to a reference laboratory, which reference laboratory it was sent to. That will be completed by the central study team. So we'll be liaising with Sarah and with Katrina, and also with Arthur Morris for New Zealand as to whether this particular isolate was received. So continuing on, so we do have a specific neonatal subform, which with thanks to Brendan Murphy Brendan McMullen, sorry, Brendan. Who helped put this together, because clearly neonates are a bit of a different group and different risk factors, and so really important information to gather. And again, probably most of the people in this room this may or may not be relevant to, but is fairly self-explanatory, particularly for neonatal specialists who know what NEC is. And this is a general kind of traditional risk factor part, and then we'll get into the more subform part in a minute. So essentially things including, did the patient at the time have neutropenia, lymphopenia, TPN, steroids and central venous access device, duration of neutropenia, lymphopenia, TPN, etc., and the type of CVAD. Then this is what kind of launches the branching logic of various subforms. Some of them do not in fact have any more information apart from saying yes, they have pancreatitis, etc. But some of them do have more information, understandably, including things like hematologic malignancy, where we want more information about what type of patient they are. And so this is just the quick snapshot of the haematology subform about the type of malignancy or condition, where they're at as far as their treatment, trying to keep it simple as far as the treatment, whether it was most recently conventional chemotherapy versus non-cellular novel therapies. And then that's because the next form is looking at the cellular therapies or BMT, which includes CAR-T and bispecific and allo and autotransplant. And dates of receipt of the most recent cellular therapy, whether there was GVHD sites involved. And we'll make sure that if there's any kind of grading, we have the grading provided for your reference, including such things like the GVHD grade. Obviously, if you cannot complete this database, based on the information that you have, you just don't enter it. Obviously, this is ideal scenario, and we'll try and gather as best we can. Solid tumours are fairly straightforward, just about whether they got chemotherapy, radiation, surgery or immunotherapy within the last 30 days, and whether they had an immune-related adverse event within those 30 days, which required treatment, because, of course, steroids and infliximab quite possibly risk for fungal infection. Solid organ transplant, tried to keep it fairly simple, just about which type of organ or organs and when was the most recent transplant and whether they'd been treated for any rejection within the last 30 days. Briefly about primary immunodeficiency, very simple information about those living with HIV, and so the CD4 count and viral load of most recent nature. Diabetes, basic information, but obviously quite interested in the SGLT2 therapies, given it's such a risk, and their control. Chronic lung disease, just some very basic information about the types of risks that they maybe have, as well as whether someone is on dialysis and what type of dialysis. Chronic liver disease, just basic Child-Pugh classification, which we can provide the definition of for those who need it. The urinary tract, we're just interested in obviously things that are quite common and place patients at risk of urinary tract fungal infection and fungemia with catheters, JJ stents and nephrostomy. Any recent surgery within the last 30 days, and given there are so many possibilities, we've left it open text for the type of operation, and we'll have to deal with that later as far as how we manage that. But it would be interesting, at least we can capture whether someone did or did not have surgery within the last 30 days. Just catching all potential other autoimmune conditions, such as the rheumatologic conditions or neurologic or gastrointestinal type illnesses that like Crohn's, and what type of treatment they might be on. Now getting to the infective episode in question, when was the patient admitted when they had their index fungemia, whether that was hospital onset or community onset or healthcare related, whether they were in ICU, and of course the duration of ICU, and some key treatment requirements if someone is in ICU, including renal replacement therapy, ECMO, LVAD, and invasive ventilation, whether someone was on prophylaxis or treatment, antifungals prior to this identified fungemia, which we'll go into a bit more in a moment with the table, and the whether this was part of a case cluster, which might be more interesting with our Candida auris or such. I've just put this in a table, but it's quite straightforward to enter into RedCap, is essentially whether you can select if there was an antifungal that someone was on for treatment or prophylaxis and how long they had been on that. Clinical features. So this is just the name of the isolate, because of course if you had a Candida and then you might have also had a Saccharomyces, it may be that there's a different thought to be organ manifestation or site of involvement. So you can select the sites that may be involved, and with the lead site investigator, just to the best of your ability, what the likely source of fungemia is, but certainly you can unknown or other if you need a way out. Onto management. So whether there was initial empiric therapy, meaning that at the time we're not you've got a yeast in blood culture and you don't know the exact organism or its susceptibility, so you commence an empiric therapy, typically in a Candida, of course, but there might be others like amphotericin, and then targeted therapy you can enter. And of course, if it's the same thing, then you just enter the same thing. So if it's in a Candida that continues, then you put that in. The overall duration of antifungal therapy post-detection of the fungemia is there, and then the overall the duration of antifungal therapy post-blood culture clearance, given the old school recommendation of duration post-blood culture clearance. Some key kind of performance indicators as far as management of candidemias: was a CVAD removed? How long post-detection of fungemia was it that the CVAD was removed? Was ID micro-consulted as gold standard? Was an eye examination performed? By who? And was there any findings? We kept it just a free text because of, you know, there can be endophthalmitis, there can be retinitis, and it's just a bit, we'll probably just get a description and then we can sort it from there. Whether an echocardiogram was performed and which type of echo, you can obviously select multiple, and based on the at the end of the day, was there thought to be endocarditis or not? And was there any surgical management of for source control, and a description of what type of procedure was performed? And then just outcomes, so status at day 7, day 14, day 30, date of death if relevant, and if relevant, what was thought to be the cause of death, and this again is by the site PI. Was this due to the invasive yeast? Was it unrelated? Was it a contributing factor, or was it really unclear? And date of discharge from acute hospital and date of discharge from the total hospital, including Heath, for instance, or day unit. Okay, so on to the just it's nice to highlight where things are up to with, maybe before I go on, sorry, are there any questions or comments or anything based on what I've just mentioned now? Lucy? Yes. No, I know. I actually, I wrote that down and I was going to talk to Safna after this. Yeah. Yes, thank you. I know. I was going through it when I was presenting it. I'm like, I'm finding all these spelling errors. I'm going to have to fix it. You're like, God, I have my work under a microscope. Yeah, no, I definitely, thank you for reminding me. No, I hate spelling errors too. Yes.
Do you have a recurrence in the same patient?
Mm-hmm. Yeah.
Months later or 3 months, you have the exclusion?
No, so after 30 days, you can include a new or another fungal isolate.
Just a quick comment too about the reference labs. Is there one for New Zealand?
Yes, so you need to enter that into the RedCap, yeah. So we'll put the New Zealand mycology reference lab in there. Yes. We hadn't included them from a collaboration perspective in particular, but I guess now that it's not so much about sending isolates for subsequent workup, we could include that as an option, because yes, now it is a practice of, yeah, thanks Sarah. I think we should collect that as well. Any other comments or thoughts? It seems long, but as I mentioned, it's also only relevant things are completed for the patients who have the relevant risks. All right, so as far as where we're up to with governance, we're kind of helping people with the application, and we're really kind of ready to submit with a number of centres, but just finalising the contract, which is literally at the last gasp of getting a formal sign-off, so we'll be very close. Now we've got, just to kind of highlight that we actually have got some really good progress from some sites about going through the process, including in the number of sites we can see of participating in Victoria, New Zealand, Queensland, lots of sites, and it's fantastic that we've got representation from all states and territories, as well as great representation from New Zealand. And I have mentioned SAPNA before, and I may in fact just get you to come up so that people can see you on the video, because SAPNA has been doing an amazing job, and so we really appreciate her work. And say hi online. I don't know, where is the camera? Is it over there? Yeah. SAPNA is really fantastic at nutting out processes, and please reach out and let us know if you have any questions. We'll try our best. So on that note, are there any questions from the group about governance, any process, any... we have received a couple of emails recently that we are going through the processes of addressing, so thank you for sending us your questions through. Nope. All right, well, so in that note, thank you for sticking with me through a very dry topic, but we'll get on to some more interesting and things that we can learn from the wonderful Sarah Kidd, who will present on basically the interesting and challenging topic of Candida susceptibility. Thanks, Sarah. And sorry, I should mention that Sarah is our head of the National Mycology Reference Centre in South Australia Pathology, and I'm sure that many of you will know her extremely well, but clearly a very expert person in this area, and we look forward to hearing your talk. Thanks, Sarah.
Thank you for that very nice introduction and for inviting me here to speak. Okay, so we're talking about susceptibility testing. Those are my disclosures. So in the ACSIII study, we're collecting MICs really to get a snapshot of resistance rates in 2024. But in the clinical setting, I guess, and saying this as a non-clinician, we perform susceptibility testing in most cases because we want some data to support our treatment choices. So I think it's always good to remind ourselves of what resistance is and the difference between microbiological resistance and clinical resistance. And sorry if I'm preaching to the choir, but microbiological resistance can be seen when we have fungal growth at drug concentrations that are higher than the MIC breakpoints. And of course, that's complicated by the fact that in many cases we don't actually have breakpoints. Microbiological resistance is associated with resistance mechanisms that can be intrinsic or acquired. Now, clinical resistance occurs when we fail to eradicate the fungus with the drug despite observing in vitro activity against the fungus, and this is associated with a high likelihood of therapeutic failure. Really preaching to the choir now, but it's worth mentioning because sometimes people don't know. An MIC is the minimum concentration of an antifungal drug required to prevent the growth of the fungus in vitro. But the problem with MICs is that you can get quite a bit of variation depending on the method that you use for susceptibility testing, or even just through very small variations in the same methods, and then it sort of becomes hard to know what it all means. So, for example, small changes in the inoculum density of the yeast will affect the MIC. Likewise, variation in the growth phase or the growth rate of the fungus will affect it. The incubation temperature that we use and the duration of incubation will affect the MIC. The media that we use, or the broth, including the type or the brand, can affect the MIC, and particularly as relates to the glucose concentration. And we know that caspofungin MICs are quite problematic due to batch variation in concentration and activity, and that's why we don't actually report them anymore. How we define and read the endpoints and how we deal with artifacts can be quite variable between people, between laboratory staff, and so those sorts of things can lead to MIC differences. And so standardization is really important. So reference broth microdilution methods do exist from the CLSI and from UCAST. And they have been harmonised to some extent, but there are still some significant differences between them that will lead to differences in the MICs. So if you take a set of isolates and test them in parallel using both methods, you will get different MICs. The differences are in the shape of the wells in the microtiter trays, which may sound innocuous enough, but CLSI MICs are determined visually, while UCAST MICs are determined using a spectrophotometer, taking away that human element. The inoculum is 100 times heavier for UCAST than it is for CLSI, and the broth contains 10 times more glucose for UCAST than CLSI. So those are very major differences. The incubation times can vary, particularly for yeasts, including Cryptococcus. And there are some small differences in the endpoint definitions for amphotericin B. So what methods are we using in Australasia? So data from the most recent QAP survey that only closed earlier this week. I've been working hard trying to analyse this. There was data submitted from 41 labs across Australia and New Zealand for a yeast isolate, which was Pichia cudrea zevii, formerly Candida krusei. There were 37 Australian labs and 4 New Zealand labs that submitted susceptibility data. Overall, 2/3 of labs indicated that, yes, 2/3 of labs indicated that they use one of the Sensitida Yeast 1 panels. Just under a third are using the Vitek 2 yeast AST system, which is automated. And just one Australian lab is using gradient diffusion strips, such as eTest. So with the majority of labs routinely using Sensitida Yeast 1, it's worth talking about it. And this is the method that will be, the MICs will be used in the ACSIII study. So this is a commercial broth microdilution test, which most closely aligns with the CLSI reference method in terms of those variables like the inoculum concentration, the media that's used, the incubation time, all of those things. The major difference is that it contains a redox indicator dye, Alamar Blue, which is quite nice because it can simplify endpoint reading, or it can confuse the lab staff, one of those. Many studies have shown that the MICs are comparable to those produced in the CLSI reference method. It has the advantages of long shelf life, being easy to set up, far less QC compared to the reference standards. It comes in a few formats. This is not an advertisement for Sensitida. It comes in a few formats. YO10, I think, is used by the majority of labs, but there's also the YO8, which contains ketoconazole, and the custom OZ-NMR-C1 panel, which includes isavuconazole, but is research use only, technically. Now, since the Sensitida method most closely aligns with the reference methods, and we want the study data in ACS3 to be as standardized as possible, the ACS3 is really only going to accept Sensitida MICs. I was going to say that if you had isolates that had been tested using Vitek 2 or eTest, or perhaps hadn't been tested at all among your Candidemia isolates, then you could consider referring them for testing. But just before lunch, Abby said there will be no referring of isolates, so I'm not going to say that. Okay. Now, in a straightforward example, reading the MIC endpoints could be quite simple because of this indicator dye. So cell growth in the Sensitida Yeast 1 panels causes a reduction of the indicator dye, and so those wells become pink when there's growth, and where there's no growth, the wells remain blue. And so the endpoint really is just the first well that remains blue. That's our MIC. But as we know, nothing is as clear-cut as we would like it to be. So what we see quite often, and particularly with the azoles, is an artifact called the trailing effect, where there is some persistent growth in the wells above the MIC. And we can see it visually because there isn't that distinct pink and blue colours. We start getting shades of purple. It doesn't mean that the isolate is resistant. There's just a small amount of persistent growth. What it does is it makes it a bit trickier to determine the MIC. So the manufacturer provides some rather subjective advice on this to select the first well with a less intense colour change. Now, if I interpret that, I would select this well here as being the MIC, so it's the first purple well. The first well that's not bright pink, basically. But you can see how this might be a little subjective and so could lead to some variation in the MICs that would be interpreted. Another way we could do it is to use the CLSI criteria, and that's to ignore colour, because in the CLSI reference standard there are no colours. We just look at cell growth. And so ignoring colour, just look at the cell growth. And we do this by looking at the plate from underneath and choose the well that has at least a 50% reduction in cell growth compared to the positive control. And so I know that nobody can see the cell growth in there, or maybe you can. But trust me, I decided that the well with at least a 50% reduction in growth is this one here, which I also think is slightly less pink than the wells to the left. But again, you can see how that might be a little bit subjective. And then another artifact that we might see is called paradoxical growth, where we see growth resuming at very high drug concentrations. So this might occur, I don't really know why it occurs, to be honest, but some possibilities are that the drug precipitates out of solution, and so there's less drug available to actually act on the fungus and inhibit its growth. Or it could be that the fungus is developing some tolerance, but that's not the same as resistance. Now, in this example, it can be easily resolved because we've got a nice run of 5 blue wells there. So we would just select, oh dear, there, the first blue well in that series. But if there's any doubt, then the test should be repeated. Ugh. Okay. Now, once we've worked out the MICs, we need to interpret them and decide how to report them. And so ideally, there would be species-specific clinical breakpoints, but we know that's often not the case for fungi. So a clinical breakpoint indicates the likelihood of a patient responding to treatment with a given antimicrobial or antifungal in our case, administered at the approved dosing regimen. I guess this definition doesn't really account for whether or not the drug can reach the site of infection. So it's only in the last decade or so that we've had species-specific clinical breakpoints at all for antifungals. These are mostly for Candida and former Candida species, and only for certain antifungals, mostly fluconazole, voriconazole, and the echinocandins. Now, this very busy table on the right, which I don't know if you can actually read it, but don't worry about that. It lists the CLSI breakpoints sort of in the middle there, and the UCAS breakpoints on the right-hand side for various yeast species where available. And if you can read it, I don't know how good your eyesight is, you might be able to appreciate that the values of these breakpoints are actually quite different from CLSI to UCAS. So just taking the first one at the top of the list there, which is Candida albicans versus Anidula fungin, the CLSI susceptible breakpoint is less than or equal to 0.25, whereas for UCAS it's less than or equal to 0.0032. And the CLSI resistance breakpoint is greater than or equal to 1, while the UCAS resistance breakpoint is greater than 0.0032. These are very different values. And so if you were to apply a UCAS breakpoint to a CLSI MIC, it's quite possible that it's going to be a false susceptible or false resistant result. So all of that said, to reiterate that we cannot mix and match our breakpoints to our methods. We have to use breakpoints that are appropriate to our methods. And if we're using Candida yeast 1, then the appropriate breakpoints are CLSI. So not only are the breakpoint values different between CLSI and UCAS, but also the definitions that are applied to each interpretive category, and particularly for intermediate and susceptible dose dependent. Although having said that, UCAS doesn't actually use the intermediate category for fungi. It only uses susceptible or resistant. But just again, reiterating the significant differences between these two standards and their interpretation, and the importance of ensuring that the breakpoints we're using are appropriate for the methodology. The latest iteration of CLSI interpretive criteria includes certain species and drug combinations that can simply be reported as intrinsically resistant. So for Pichia krugii, formerly Candida kruzii, it doesn't have a clinical breakpoint for fluconazole, but we can report fluconazole as intrinsically resistant. The Basidia MIC yeasts, Cryptococcus, Rhodotorula, and Trichosporon can all be reported as intrinsically resistant to the echinocandins, and Rhodotorula species are also resistant to fluconazole. CLSI do make the point that Candida lusitaniae is not intrinsically resistant to amphotericin B, despite popular opinion, but it can easily develop resistance in vivo. In the absence of breakpoints and advice on intrinsic resistance, another tool we can use are epidemiological cutoff values, abbreviated as ECVs, or perhaps you know them as ECOFs. So ECVs define the upper limit MIC of the wild-type population of a species. So wild-type populations have MICs that are associated with an absence of resistance mechanisms, and non-wild-type isolates have MICs that are associated with with acquired or intrinsic resistance mechanisms. So isolates with MICs at or below the ECV would be considered wild-type, and isolates with MICs above the ECV would be considered non-wild-type. But importantly, ECVs do not predict clinical response. Just to summarize the differences between a breakpoint and an ECV, clinical breakpoints require MIC distributions to develop, as well as pharmacokinetic data and treatment outcome data, whereas ECVs are based solely upon MIC distributions. So breakpoints are actually therefore difficult to generate because treatment and outcome data are quite rare, while ECVs can be generated more or less for any species, provided we have sufficient isolates of it. So breakpoints allow us to interpret MICs as susceptible, intermediate, resistant, and so on, and predict clinical response, while ECVs allow us to interpret MICs as wild-type or non-wild-type, and they do not predict clinical response. But both can be used to identify isolates that may be harboring resistance mutations. So there are quite a number of CLSI-endorsed ECVs now for interpreting MICs in common yeasts. And so even in the absence of a clinical breakpoint, we can still interpret MICs for many fungi and drug combinations, and we can put those interpretations on our lab reports. So as an example of what that might look like on a lab report, say for a Candida tropicalis isolate from a blood culture, these MICs have been generated using the Candida yeast 1 YO10 panel in our lab. And so we've applied CLSI breakpoints where they are available. Where they're not available, we've applied ECVs, so posaconazole, itraconazole, and amphotericin B have had ECVs applied to determine whether they're wild type or non-wild type. And then there is some very extensive comments there to detail exactly what wild type and non-wild type means, and importantly, what they don't mean. And they look very long-winded, but that is the exact wording recommended by CLSI. I think it's important to include MICs on the reports. And the question came up earlier about how to manage susceptible dose-dependent isolates of Nicasiomyces glabratus, Candida glabrata. And I think that's where the MIC can be very useful, because susceptible dose-dependent goes all the way up to 32 for Candida glabrata. And so there'll be a big difference between an MIC of 2, for example, and they do happen in Candida glabrata, and 32. And that, having the MIC could help guide your decision making on whether or not you would use fluconazole in that situation. So MICs are important. Now, when we're faced with a report that interprets some MICs as non-wild type, remember, it doesn't necessarily mean that the isolate is resistant, but it does mean that there needs to be some multidisciplinary discussions on things like whether the dose can be increased to improve the likelihood of success, or perhaps if there's another antifungal that should be used instead. I'll mention Candida auris, which is a bit of a special case, and just in Adelaide recently we've been seeing quite a few cases, much more than we're comfortable with. Since Australian cases are currently still quite sporadic and associated with travel, it is recommended that susceptibility testing be performed on all isolates from both infection and colonisation, I think, because we want that data. The most accurate method is by broth microdilution, and the reliability of other methods for C. auris is not clear. But despite recommending susceptibility testing on all isolates, the biggest problem we have is a lack of interpretive criteria. There are CLSI ECVs for the echinocandins, but there are no clinical breakpoints. Now, the US CDC has released what they refer to as tentative breakpoints to assist in identifying likely resistance, but it's really important to note that these are not clinical breakpoints. They do not predict clinical response. And even if an isolate were to be classified as resistant by these tentative breakpoints, it shouldn't necessarily exclude that antifungal as a treatment choice. But I think clinicians could find them useful just as something to guide how to interpret those MICs. Because the breakpoints, tentative breakpoints, are not validated or endorsed, I would suggest not using them to interpret MICs on lab reports. But if they were to be used on lab reports, then obviously a very carefully worded comment would be required. Come on. Why is it only I'm having problems moving the slides along? Now, there is a new development in antifungal susceptibility testing, and that is that the RCPA has released an update on selective reporting, which includes advice on antifungals. So this was released at the end of May. And as we all know, this is an important component of antifungal stewardship, reporting results only for those antifungals that are recommended for treatment or that should be considered for treatment because of unexpected resistance. So just taking one of the tables on Candida from blood, for most Candida species that are susceptible or susceptible dose dependent or wild type to fluconazole, we would want to nudge the clinician towards using fluconazole, I guess. And so the lab would report the fluconazole results and the echinocandin results only if they were following these guidelines. But for those Candida species that are resistant or non-wild type to fluconazole, then we need to provide some alternative options. And so that means reporting voriconazole, posaconazole, amphotericin B, and the echinocandins. But specifically considering Candida glabrata, or Nicasiomyces glabratus, so that's now known, if fluconazole is susceptible dose dependent, then we would report fluconazole and the echinocandins. But if it's resistant to fluconazole, then we would report fluconazole, posaconazole, itraconazole, the echinocandins, and amphotericin B. There is a footnote there to say that there's insufficient data to establish a correlation between voriconazole MIC and outcomes in Candida glabrata, and perhaps to avoid reporting the voriconazole MIC. Now, there's other tables as well in these guidelines for yeasts from other sites, from urine, gynecological specimens, some advice on basidiomycete yeasts, as well as molds. And so we could consider implementing these for routine use, which my lab has not done at this time, and it seems like a lot of IT headaches for us. And I guess as a reference lab, one of the other issues that we have to think about is that if a lab is referring an isolate to us to be tested against a panel of antifungals, can we really justify withholding most of the results, or do we just release all of the results to refer to the referring lab and let them report them how they see fit? I don't know. These are things we're thinking about. So coming to the end, summarising, MICs are useful if they're accurate, if they're reproducible, and if they're interpreted appropriately, but they're not really comparable if they're obtained by different methods, and they can be misleading if interpreted using inappropriate breakpoints. So only Sensitida MICs are being accepted for ACS3. I'll walk back my comments about referring them if they've been tested by other methods, although perhaps that's something that could be discussed a little bit further. Current CLSI breakpoints, or ECVs, if they exist, can be applied to Sensitida MICs, but if not, report the MIC alone. And finally, just consider maybe how your lab might be able to implement the new RCPA guidelines on selective antifungal reporting. But for the purposes of ACS3, all MICs are welcome. I'll just finish there by acknowledging the organisers of the, or the brains behind the ACS3, as well as ANSMIG, and people that I work with, and Catherine at QAP, who got me those results so quickly.
Thanks, Sarah, for a very enlightening talk. Certainly for me, who's a non-microbiologist, it's always very helpful to remind us about how these things are performed and the limitations and other things. Do we have any questions online or in the audience? First off, I'm going to ask maybe a provocative question. It's just more out of interest. I think I was talking the other day to someone, and it came up, about with the change in the nomenclature, is there any kind of edict or idea from RCPA or others about how things are going to move forward with, do we still report the old school name and the new school name, and how these things are planned to go forward from here?
I think at this time there's no guideline to follow on that, but I would always recommend reporting both names for as long as you feel that it's necessary. We could still be here in 10 years reporting both names, and I think that would be fine, and no one would complain about it, and it just makes everything clear. I personally prefer new name, old name, but if people feel more comfortable with old name, new name, whatever. But and I think reporting both names, that serves to educate people, people in the labs, people in the people who are treating the patients, I think education is key with this, and the more we report both names, the more we sort of drive that message home. So I don't think anyone would disagree with that, to be honest. Reporting both names is always helpful.
And I guess from a lay perspective from my end, there's probably no downside to reporting both, like as far as it's, once you've set up the system such that it's easy to do that, then there's really no downside in continuing that, would you say?
Yeah, I would agree with that. Yeah. I think it's setting up your LIS to report both names simultaneously can take a little while, but I think once it's done, very easy just to let it stay that way. Yeah, I don't think there's any downside to it.
Right.
There are some people in the world who would rather this was not happening and just want to cling on to the old name forever, but no names. I think that we just have to move forward and educate people as we go.
Excellent. And is there anything kind of, any other hot topics or things that you'd like to think about from the kind of Candidemia perspective from a lab front that we should be looking at in the future? Obviously very
put me on the spot.
On the spot, tough question. and feel free for anyone else in the audience to kind of raise their hands about any ideas. I think one thing I was talking about before is that with so many sites involved and this great kind of goodwill that we have, there are always questions and topics that we could then think about looking at in the future.
Mm-hmm. Does anyone else have any thoughts on, things that the lab should be thinking about in terms of Candidemia? I don't know.
No. I think, as we talked about before,
put it in the chat.
With the new drugs coming, there will be obviously probably at some point some need to look at expanding the, susceptibility testing.
Yes, yeah. Actually, I forgot to say. I was going to say that there are no labs in Australia really that are routinely performing reference methods because they're so labour intensive. But Sharon's lab and Katrina's lab at Westmead do occasionally perform, I'll probably get this wrong, the CLSI standard. I'm not sure if also the UCAS standard for drugs, new drugs like olorifim and coming up to fosmanogepix, where there are no commercial testing options available yet. So hopefully they will be commercialised in the future when they're sort of approved.
Okay.
Sarah and everyone, Monica spoke about rezafungin earlier today, and rezafungin is marketed by Mundi Pharma, but their partner is Clinigen in Australia, and they are looking to get rezafungin into use in Australia. In terms of their susceptibility testing, the CLSI has another plate. So they've got their normal plate, the Oz MRC plate, and another plate with rezafungin in it, but -5 FC. So that, I think, may be an option.
That's available. Is that the YO11? I think it's available only in the US at the moment.
Yes, that's right,
yes.
Sarah. So, but it's certainly an option for us to think about, because if we're going to get rezafungin into the country, at least when we start using it, it would be nice to have an MIC.
So we could ask Thermo Fisher.
Yes.
What's possible.
Yes.
Yes.
And Sarah, I saw you mentioning there was the panel with the Oz one with ACSIII Conazole. Do you know whether any centres are using that?
Yeah, I invented that panel. Thank you. It's just a Sensitida. It's a Sensitida yeast 1 panel. I should say Katrina assisted with that as well, since she's online. It's almost the same as the YO10 panel, but we've taken out caspofungin, which is not reliable in the MICs it produces anyway, and we've put isavuconazole where it used to be. So it's almost exactly the same as the YO10 panel, just with isavuconazole. So it is technically regarded as a custom plate, but and research use only, but it is available in Australia. My lab uses it routinely, like for everything. I think Westmead, they also do, I think there's probably 5 or so labs that are using it.
And are they clinical breakpoints, or is it wild type, non-wild type?
I don't think there are any isavuconazole clinical breakpoints yet.
Great. Excellent. Well, thanks so much, Sarah, for your presentation. Please have a seat. I'll just close
Few
off.
bonus slides on the end of my talk. There,
Amazing.
past them.
Thank you. I don't think I have maybe I do have a closing slide. I don't think I do. But essentially that brings us to the end of the formal session today. I think I did probably omit to talk about timelines, but I guess it's more about practicalities. So we would certainly encourage people to start the ball rolling, please, with the governance process, and SAPNA's very great at helping facilitate that. And we'll have our DTA hopefully within the next week. And then once we have governance, obviously once we get the correspondence to the central site, then you're certainly welcome to commence. We can touch base as well, probably on Teams, if there's any more kind of an informal site or a formal site initiation visit, just to answer some questions that you have and help with the RedCap. But otherwise, the aim would be to try and complete data collection by the end of the year. I think would be fairly reasonable. Obviously, if there are delays with getting governance, then we can set that back a little bit. But I think 3 or 4 months post governance approval, I think probably gives us people enough time to collect data, and we're very happy to help wherever we can, so that hopefully by the end of this year we'll be able to have a nice snapshot of last year and have something that's more up to date into the 2020s. I'd really like to thank, did you have something to say? Yeah. Sorry, Sharon.
Sorry,
I'll just do that.
I'm sorry, I'm being very clumsy today. Thankfully, not everyone online can see. Okay. All right. Sarah, we brought up the fact about doing AST by Censitita, and Sarah's slide shows that 12 out of something labs use Vitek.
Yes.
Right. So can we open the discussion about whether the labs using Vitek could send the isolates on for Censitita, and how does that affect the governance, and how does it affect what everyone thinks?
Yeah.
Some of them may not store.
I think with blood isolates, you're meant to store them for a defined period of time.
Not meant to.
Yes.
So it would be, there's the kind of material transfer agreement, and these are the kind of, because it's transferring of an ice of.
So the current ethics doesn't cover the transfer of isolates.
No, that kind of devolved into a fairly complicated process. Things have got a lot more complicated as time has gone on, and so individual material transfer with money transfer, et cetera, for each site, for the 65 sites, was getting quite unwieldy. Yes, that's where it stood.
It's a pity, because then you'll have 2 subsets of susceptibility data.
Yeah.
And what do you think? Right. And Kate, would you have
Yeah, I was going to maybe talk to you guys a bit more about this. We have quite a lot that were done on the Vitek.
So would say Queensland Health required MTA to transfer isolates to South, to SA Pathology, or to?
Well, no, we do have the materials because we do have sensitivators, but the Vitek's the high throughput method, and that's a workflow choice. I haven't got a great answer off the top of my head. So I guess it's something we should talk about.
Mm. Yeah, that's a good question, Sarah.
If we were to find out that this actually, half of the participating centres use VITEC, we might have to rethink.
Yeah. And I think it's a good point you raised, Kate, I guess, with the Queensland is a quite in the best way, a unique setting where it's quite centralised. And so we could potentially look at a amendment to allow, the Queensland sites, your lab in particular, to and even look at.
I mean, there are labs
funding.
In Pathology Queensland that do use Sensitida.
Yeah.
Right, okay.
We'll pass to Dan.
Certainly not in the lab myself, but having dealt with some of these sort of material transfer agreements, I wonder whether, in terms of funding and cost and ease, whether that would be a smaller cost for the sites that are using the VITEC to just sort of test their isolates on Sensitida, enter the data versus centralising things, because that's just ridiculously complex. Isn't it?
That's right. So that's kind of what I think might be a solution in particular for Queensland. We do have a small amount of funds that I think it could be reasonable to allocate to large throughput if there's a lot of non-Sensitida testing. So we'll discuss it just to see what, and I think Sarah's point about assessing the lay of the land. So we'll send out an email just to get a sense, maybe a small survey monkey or something like that, just to get a small sense of what's being done where, and therefore the proportion we think is probably going to be affected by that. We might be able to centralise a couple of hubs that, well, not centralised, but the high, the labs that do a lot of sampling, a lot of testing, if we need to retest. I'll give this to you. Okay.
Yeah.
Thanks, Abby. And I can't answer everything, but I guess to contextualise, when we're doing a feasibility assessment in our state, we just did a broad interrogation of the database, and there's about 200 yeast blood culture isolates across the state, so it's quite a lot. In terms of how many is Sensitida versus how many were VITEC in that 12-month period, we could probably find that out, and maybe that would inform what's possible.
Yeah. I think that sounds really helpful. So we could keep the conversation going, and we'll get the situation as far as how many are affected to see if we can come up with a way to maximise the Sensitida results.
Yes, I think so. And if it's a question of costs, perhaps we can dig around. I'm not looking at Monica. We can dig around and try to, support if it's a question of money. Yeah.
Yes, so I might just make a comment there too. And I think it's really important to recognise that, we have had this educational grant from Pfizer, which is supporting the meeting today, but is not, they're not offering us any money to actually run the study or support the study. So they were very clear that it could be used for education around Candida and education around the study, but they weren't actually funding any of the mechanisms of the study, like, the cost of governance or the cost of ethics or the cost of creating the RedCap or anything. So if we do have to do these additional things, and that's why I think we decided against these material transfer agreements, which would cost money and take time. So if we do need to find money, it will be coming out of our own individual research centres, and it is possible that we could look at that, but just so people online and, who are contributing, it's largely done on people's goodwill, the funding of this study. I think that's important to acknowledge.
Kate also brought up an important, was it Sarah and Kate brought up an important point. So in Queensland Pathology, you are one organisation, and referring to a lab that does Sensitida is not going to require transfer agreement because you're the same organisation, such as, and similarly for New South Wales HP. So if Anne and I wanted to change isolates, we could freely. And I guess that's a similar arrangement in WA, and in ACSIII, you kind of do mycology in one lab, right? One lab, right? And in Victoria,
No,
suppose
dog's breakfast.
right. Oh, okay. Yeah. I think there are ways around, and we should look to it because the susceptibility testing is one of the keys of the study, and we don't want to be in a situation where we can't write about it.
Yeah. Lucy?
Oh, sorry.
It's just on the same point, though. I would caution against sensititer trays going to laboratories that don't have experience in using them, which was, I think, one of the points that was raised, was that could you get the sensititer tray to the laboratories that don't normally use them? I would caution strongly against doing that because the trailing phenomenon and interpretation could make significant impacts upon the data received.
Oh, no, sorry if I was unclear. I was not suggesting that. I think it was Kate who was saying that you do some sensititer but mostly Vitek, so you do have experience there.
And so then I guess just, sorry, I'm chatting away with Natalie, who's
Caitlin's putting her hand up, but sorry, go ahead, Kate.
Sorry, well, it'd be good to hear what Caitlin says. I'm just chatting away with Natalie, who's the Pathology Queensland lead here as well. And I guess one thought from me specifically is that if we do have, 20-30% of labs using Vitek, is there some value in that, as you know, so that we are seeing sort of real world outcomes with different types? And then with that in mind, is there again value in maybe doing a subset where we're doing resuscitating the isolates and sort of doing some comparative testing, but it might not be feasible for 200 isolates, but perhaps it's feasible for 20 or 30 in our setting. So that's a thought. I know I'm sort of bringing this up after it's clearly all been discussed, but yeah.
I like that idea, I guess, and data is data, so the Vitek susceptibility data could be interesting
Abby,
as well.
I'll add to that.
Sorry, Caitlin.
My question is, can you hear me? Because my question is basically the same. It's related, so you can answer both at once. And my question was, that was such an interesting point. And is there, what would be the scope for, I suppose, a sub-study of Vitek versus sensititer and looking at some of the potentially troublesome organisms?
Didn't quite hear the last thing you said. The troublesome organisms, yeah. I'm not going to comment. Yeah.
You have to roll them.
Yeah.
I think any resistant isolate for maybe a second antigen. We would
Sorry, for those online, Sharon was saying it would be good to confirm the resistant isolates, and oftentimes Westmead may refer on to SA for a second opinion to ensure that what's called resistance is in agreement. So I think we can certainly, first steps will be to see what the situation is with how many centres are doing what and the likely proportion of numbers of isolates that are going to be affected by that, and could look at considering whether we can be retested on sensititer in the first instance in those labs that have experience with sensititer. And yeah, we'll keep the conversation going about that, I think, with Sharon and with Katrina and Sarah. Yeah. Awesome. Any other comments or questions or thoughts about things in general? Otherwise, I'd really just like to thank Sharon and Monica and Sarah for their time and for coming across today and speaking, and for everyone's attendance and input. It's been really fabulous to work with everyone, and it's, I think, a real tribute to everyone that we have such a collegiate group, and to ANZMIC's credit. And I think it's something that we can certainly be proud of and build on and use these, you know, each time we do these kind of studies, we learn more and we the processes and things get somewhat smoother, and so we may be able to do some more exciting things in the future, potentially even interventional and more kind of exploratory. So thanks everyone, and we'll close off today and wish everyone a fantastic weekend. Thank you. Oh, thank you. It was really great to see, we had